Okay, let's kick off. There will be a few stragglers, I'm sure, sort of joining us as we progress. But I'd like to start by thanking you all for joining us this evening on behalf of the chairs of the 4 branches within sort of the Ireland region who are with us this evening. As I say, so we will be recording for GDPR compliance. We just turn your videos off. We'd like to welcome the presenter this evening, sort of Dr. David Gold, and Dr. Andrew Sharman, sort of the president of IOSH, who has very kindly joined us and will be giving the opening address. And from my perspective, sort of, some of you know me, some of you don't know me. I'm Michael Collins. I'm the regional manager for the Ireland region, and have been working closely with the chairs to get this event off the ground. So we'll crack on at this stage, and I'd like to welcome Andrew, if you would give your opening address, please.
Very good. Thanks, Michael. Good evening, good afternoon, everybody. I'm Dr. Andrew Sharman, president of IOSH. Thank you for welcoming me to your meeting today. I'm very proud to be here today as we see a first-time collaboration between all 4 IOSH branches in the region, with members from the 3 branches within the Republic of Ireland and the branch in Northern Ireland. One IOSH is one of IOSH's values, and it's truly reflected in today's collaboration. This collaboration will support how we enhance and influence to support the institution. Not long ago, I addressed you all with the presidential address, where I spoke about how COVID-19 has changed our lives. On the flip side of our negative feelings, as there will be many, COVID-19 has positively forced us to change the way we reach out and communicate. Zoom has become our best friend and created an opportunity for wider collaboration. It is unprecedented for all IOSH branches in a single region to come together and collaborate in this scale, as you've done this evening. And it's fantastic to see the Ireland region leading the way for the IOSH world, which will encourage other branches across regions around the globe to follow suit. Thank you for your leadership, Ireland. I would just like to take this moment to congratulate you all for coming together. Today you'll hear from Dr. David Gold, one of our vice presidents, who will be delivering his presentation on mitigating the COVID-19 comorbidity of post-traumatic stress disorder, PTSD. With any significant biological, medical, or traumatic injury, there are often comorbidities, sometimes immediate, sometimes months after an event. Not only the victim of the incident may suffer the comorbidities, but also witnesses, caregivers, family, and friends. PTSD is a well-documented comorbidity with individuals suffering from COVID-19. The aim of the presentation you'll hear today is to raise awareness of the safety and health professional, the people in the organization they serve, and others about the nature of PTSD and how to deal with situations arising from a post-traumatic stress disorder. I really hope that you all take something useful away from that today. So before I hand over and leave you today, I just wanted to reiterate how important today's collaboration is. This level of connection that you're demonstrating can only be good for your members, your volunteers, your branches, and your region. Thank you again for your leadership in this regard. Staying connected is one of the key steps to well-being for us all. So please take the time to look after yourselves as well as your loved ones, your colleagues, and others. Stay safe, stay well. Thanks again for being here this evening.
Thank you, Andrew. It's a great way to start the event. Right, from this point, I'd like to introduce our main speaker, Dr. David Gold. David is a Chartered Fellow of IOSH and an active occupational safety and health practitioner. He's the founder and managing director of Gold Necht Associates and an international consultant providing expertise in occupational safety and health policy, workplace fire prevention and protection, workplace health promotion, occupational safety and health training, capacity building, managing psychological issues at work, and behavior-based safety and health. He also offers courses and coaching on presentation design and delivery. In this capacity, has furnished leadership expertise and training for private industry, international organizations, and non-governmental organizations in Europe, the Americas, the Middle East, Asia, and Africa. He serves as a senior consultant to DuPont, the Fair Labor Association, the International SOS Foundation, and the Foundation Netcare. He's a member of the International Commission on Occupational Health, the Swiss Public Health Association, and as I said, he's a chartered fellow of IOSH. So at this point, I would like to welcome David, and if you would like to share your screen.
I will.
Just as David's doing that, can I just remind everybody that there will be a question and answer session at the end of the presentation. So we would ask you, if you have any questions, to either post them using the chat function, the chat button at the bottom of your screen. We'll monitor those and we will put them to David at the end of his presentation. Thank you very much, David.
Thank you, Michael, and thank you, Andrew. Very sincerely, I'm very proud to be working with you, to be talking to you today, and also the significance of this meeting. As some of you know, some of my friends know, that I am 100% Irish, and I'm not Irish at all by blood, which means I come from Boston in the United States. And anyone born in Boston, as I was, we consider ourselves Irish. So I'm very proud to be working on the island of Ireland with all of you in this very important day where we come together to address a very important issue. As we get started, I'd like to just express my gratitude to Michael and Catherine from the IOSH perspective, as well as Fabian, Emma, Bruce, and Ruth, who have been working together to allow us to have this meeting today. As Andrew said just a few minutes ago, our aim for this program is to raise awareness on important issues dealing with mental health during the COVID-19 pandemic. Specifically for this session, it's to raise awareness of the safety and health professional and the people working in the organizations they serve, such as healthcare workers, emergency workers, or responders, and others working in critical services. The scope of what I'm going to be doing, based on the above mentioned information, will cover the risk of post-traumatic stress disorder, PTSD, associated with the pandemic, understanding the signs and symptoms of the disorder, and what can be done on an individual or organizational level. And I'm going to conclude with an information sheet that we will distribute to each of you, so that you can use this with your friends, with your peers, with your colleagues, with your family, to share this sort of thing. Now, those of you that have worked with me before know that when I do a presentation, there is no need for you to take notes, as the presentation and its speaker notes will be sent to you as a PDF by Michael once we complete the presentation. So it's just going to come to you automatically. If Michael has your email address, you'll be receiving it in due course as a PDF. So on that note, I'd like to just get started very briefly with a poll. And as a first poll, I'd like to ask you a question. There's going to be two polls. I want to stimulate your thinking a little bit, but do you think that post-traumatic distress disorder, PTSD, is a medical condition that is increasing as a result of the COVID-19 pandemic? So I'm going to ask you, if Michael will start the poll, thank you. If you would just simply tick the yes or the no box and hit submit. And once we have the majority of the people that have gone through the poll, then we'll take a look at the results. I'll give you a minute to do that. How's it looking, Michael?
We have 88% yes, 12% no.
88% yes, and 12% no. And how many people have completed the poll out of the 49 on board?
41.
41. That's great. So obviously, you have a sense that PTSD is associated, is a comorbidity, as Andrew said a few minutes ago, with this situation. I want to share with you something that reinforces that. At the Queen's University in Belfast, I came across an article which basically was researching the COVID comorbidity, or the sharing of the relationship between COVID-19 and post-traumatic stress disorder. And a professor whose name is Sherry Moore basically came up with the fact that 1 in 5 of the people that were interviewed in Northern Ireland had a PTSD associated with the current pandemic. So she interviewed 470 people. It's a fairly small cohort, but there is a serious significance with the relationship with COVID-19 and PTSD. So let me move on and into the presentation a little bit. And those of you that had seen the presidential presentation on the interrelationship of psychosocial issues may remember this slide, but it's important that I come back to it. The science of public health suggests that there are 3 levels of prevention. It's not that different than the way we think. But primary prevention basically is keeping healthy people healthy. Secondary prevention is when people start to show signs or indications that there's a problem, that we need to try to mitigate this problem. And tertiary prevention is when people are ill. We need to figure out how to provide support for them and potentially the people around them. So our goal should be to keep ourselves healthy and to try to keep the workers working around us healthy. And when the stresses around the current situation start to increase and people start to show some of the basic signs that I'll talk about in a few minutes, the next step is to try to mitigate this effect by different measures that we can use, different interventions that we can use in the workplace. And the third step is when people start to reach the point where people are getting sick, then what can we do to actually provide support and help them? So let's talk a little bit about post-traumatic stress disorder. PTSD basically is a psychological medical disorder, which even, as I'm going to share with you in a few minutes, the strongest of us may suffer. I suffered PTSD, and as I say, I'll talk to you about this later, when I was an emergency firefighter paramedic in the United States. And I thought I was a pretty tough, pretty strong guy, young father at that point in time. But it can happen to anyone, anytime whatsoever. A scientific study that was conducted during the SARS epidemic looked at healthcare workers, and they were questioned. And the healthcare workers in Beijing expressed increased levels of PTSD since the outbreak. And indeed, this is continuing. So I think I've actually already brought up the topic of this next slide. PTSD addresses a psychological medical disorder that any of us, the strongest, the weakest, any of us may suffer. And although it's normally associated with witnessing trauma, and if you go back to even the First World War in the 19 teens, if you like, it was called shell shock then, it wasn't called PTSD. We know that during this disastrous pandemic, that it's significant, it is seriously there. So let's take a look at the fact that anyone can experience this, family, friends, but at a higher risk are emergency workers and healthcare workers. The year for me was 1975. I was living in Henniker, New Hampshire, a small village, about 100 miles north of Boston. And I was functioning as the lead paramedic on a rescue team. There were 3 of us that would respond normally in the back of a rig to an emergency, and we also had a driver. And we got a call one evening, an October evening, at approximately 7 o'clock at night. It was getting dark, and we got a call for a motor vehicle pedestrian accident. The young lady that was hit from behind by a drunk driver who was 92 years old, who had glasses the thickness of the bottom of Coca-Cola bottles. He hit this young woman from behind, and her head hit the front of the car. What we didn't know at the time is when she was hit, when the back of her head hit, there was significant trauma to the back of her head, that the blood vessels that fed her brain were basically closed off by the swelling tissue, the edema that was around the blood vessels when this happened. So in responding to the accident, our first priority, she was not breathing. She had a heartbeat. We maintained cervical traction to protect her neck. And at the same time, we kept her alive, at least biologically alive, with an ambu bag and oxygen, 100% oxygen going into her. We had a 20-minute run into the hospital, and I was basically married to her neck, keeping cervical traction and monitoring the airway while my team was working on other aspects that were related to it. We got to the emergency department at Concord Hospital, and again, I was glued to the cervical spine and watching the face of this young woman. And at the ER, there was a decision made immediately to call in the neurosurgical team. And they decided that they would drape my arms while I was holding cervical traction. They brought me into the ER, and I stayed in the ER for 3 hours while the emergency medical team, the surgeons, tried to work to save this girl's life by introducing drugs and doing all kinds of procedures. But at the end of 3 hours, she was pronounced dead. We got back into the rig about a half hour later. We were pretty well shaken up by this. All of us knew the girl. And we got back to the rescue barn 25 minutes later. And at that point in time, one of the 2 emergency medical technicians that was working with me, he was so angry about what happened that he took his fist and put it through a gypsum wall. And from that time, for maybe 6 months, a year, he started to have tendencies toward violence, both physical and verbal aggression. And that violence lasted probably 10, 15 years beyond the incident. He was never violent before that. The second emergency medical technician that night dove into a bottle. And it took him 15 to 20 years to actually climb out of that bottle. He became seriously addicted to alcohol, played around with drugs a little bit, could not function as an emergency medical technician. And both of these were PTSD. Now, what about Dave Gold? I had I have to be careful how I speak this because it still hits me when I talk about it. I had the excellent opportunity to marry the woman of my dreams, and she basically pulled me through this by spending the nights holding me, talking to me, discussing this, and helping me work through it. When I would wake up at 3 or 4 o'clock in the morning, reliving the event, she was there for me. She was working with me. I didn't even know at that point in time what PTSD was. It took 3 or 4 years later when I was at a conference at the Emergency Management Center in Emmitsburg, Maryland, where there was a speaker that was talking about PTSD. And at that point in time, a little bit of the weight was lifted off my shoulders because I knew what was wrong with me. But even to this day, I still experience it once in a while, a memory of this event, or something will trigger it. And it might be a smell, it might be something that I see, it just triggers it, and it's there, and I work through it. It gets less and less over time, but I think I'll carry it with me the rest of my life. According to the University of Pennsylvania School of Medicine, the timing differs with each individual. For me, the timing occurred immediately. Basically, once the adrenaline wore down, once everything kind of stabilized, once we got the rig back in shape and we had time to think for a few minutes, the symptoms were there. Usually the symptoms occur within 3 months of the event, but sometimes they're delayed for months and sometimes they're delayed for years. Let's talk about some of the signs and symptoms. And I think from what I've shared with you, my story, you can already piece together some of these signs and symptoms. The first one might be reliving the event in one's mind, which happened to me and still happens to me. Sometimes there will be a certain amount of avoidance. You want to avoid that kind of situation. As a person who is involved in emergency medicine, a person who is involved in firefighting, seeing a lot of road traffic accidents and everything else, there's no way I could avoid this type of work. There's no way I could avoid this kind of situation, but some people will go out of their way to avoid it. Sometimes being easily startled is a sign and symptom of PTSD. This is especially true with military veterans who have what they used to call shell shock, but they may have had a situation where a loud noise or a blinding light or a quick flashing light may trigger this kind of thing. A common symptom that I've heard from a number of different people is the difficulty in sleeping, and I suffer this as well. 3 o'clock in the morning, 4 o'clock in the morning, you have a dream, you wake up, you experience it, you're in a sweat, your pulse is racing, you have emotional sort of feelings about this kind of thing. Some people, and I shared with you, one of my colleagues turned to violence, verbal and physical violence. People may have emotional outbreaks, emotional outbursts as far as PTSD. And some people, it wasn't in my case, had difficulty remembering the event. And this probably is a protective mechanism where people want to just kind of exclude it from their thinking. And there are people that will have they'll blame themselves. If only I wasn't there, if only this didn't happen. The feelings of guilt, the feelings of self-blame can be often present. So let's take a look at some of the risk factors or some of the issues that increase the risk of PTSD. So one thing is seeing others hurt, sick, or affected. And we may simply have an emotional attachment to an individual in our office, in our workplace, in our family, and we find out that they are either very sick or they have actually died of COVID-19. And that actually can trigger this as well. So it may be an emotional trigger. Oftentimes, seeing a dead body will trigger this. Now, as an emergency paramedic, a firefighter paramedic, unfortunately, I've seen a lot of dead bodies. It's part of the rescue world. But in those of you that have been involved in rescue or involved in the military, in the active service, that may happen. But someone who is not used to that, this could also trigger PTSD. People that have experienced some form of childhood trauma may actually be a precursor, but it may not be to PTSD. Also, a factor that increases the risk is a feeling of horror, helplessness, or extreme fear. The next one I'm going to share with you, I want to underscore 3 times. Andrew, when he gave his opening address, his excellent opening address a few minutes ago, he talked about the fact that we should take care of ourselves, we should support each other, we should work together. People that have little or no social support after an event are people that are likely to become traumatized with post-traumatic stress disorder. And one of the things that I'll talk about shortly is the idea of seeking support, seeking help, working together to get this kind of support. It becomes extremely important in this sort of thing. In fact, I think all of you know that there are stress related to work, but stress related to outside of work. There are basically 3 issues that drive stress. One of them is the perception that people have a high demand. A second is the perception of the control over the demand. And the third is the perception of social support. We know when the demand is perceived as high, the control is perceived as low, and social support is perceived as low, people start to slide down a very, very slippery slope in stress toward burnout, toward depression, toward a variety of different factors. The same thing holds true with PTSD. Social support is one of the key issues early on where we can be helpful with our colleagues, with our friends, with our family. And also related to that are people experiencing high levels of stress after an event. Let's first of all share, or secondly, not first of all, but what we shouldn't be doing, what not to do. The first thing is, don't feel guilty. You shouldn't feel guilty that you survived. You shouldn't feel guilty about the situation that occurred. The second thing is, which is related to what I spoke of to a few minutes ago, don't keep it to yourself. Don't expect memories to go away immediately. Mine have not gone away. They've diminished, but they're still there. I can still see this young woman's face. Don't expect too much of yourself. You need to give yourself a little bit of time to heal. But at the same time, don't stay away from other people. And another piece of advice is don't abuse alcohol and don't abuse drugs. Now I say abuse, I'm not saying abstain, but I am saying some people will want to perhaps intake their alcohol or intake tobacco or intake drugs to deal with some of these issues, to help alleviate some of the burden that they're going through. And the idea of avoiding abuse of alcohol or tobacco or drugs can be very helpful. Let's talk a little bit about factors that promote healing. If we keep life as normal as possible for the victim or for ourselves, this is extremely helpful. If we talk to someone, especially someone that one trusts, it might be a coworker, it might be someone in the medical profession, it might be a psychologist, it might be someone from an employee assistance program, but having someone to talk to that one trusts will also help. Another thing that we should do is we should go back to work. Don't avoid work. We need that social stimulus. We need that social support. Now that's a challenge during COVID-19, as some of us have a certain degree of isolation, and we can't go back to work yet. And things seem like there's another wave coming of COVID-19, and we may be away from work. But at least we have a telephone. We have ways of communicating, and I think we should use them. Exercise and eat well. Expect to get better. And speak to someone medically, such as a doctor or a psychologist or someone that you trust. So that gives you a little bit of alignment about PTSD and what we need to be thinking about. I want to go to a poll, and then hopefully I will provide an answer to that poll as I share the last couple of slides with you. So the second question I'd like to ask is, do you feel that you or your colleagues are in a position to provide psychological support during a crisis? And please respond yes or no. Michael, I'll take a cue from you when you feel that we're ready to move on.
Yeah, we have 27 people have answered. We'll just give it a few more seconds. Okay, so we have 31 of 44 have voted. 58% yes, 41% no.
Maybe I can convince you otherwise in the next few minutes. If I can, that's fine. If I can't, that's fine too. But let's take a look at that. We still are a little more yes than no. Therefore, 22% of you, or sorry, 22 have said yes. But let's move on to the next slide if we can. And let's talk about what we as safety and health professionals can do. And maybe you'll revise your thinking a little bit, because there are certain things that we can do. And maybe we're not going to be doing them ourselves, but maybe we're going to facilitate this in the places that we work. So as safety and health professionals, we may be approached by someone who has been impacted psychologically by the pandemic, or we may have a team of psychological first aiders that work with us, or we may have an organization such as an employee assistance program that works with us. In 2016, the World Health Organization proposed the idea of psychological first aid. Now, when I first learned first aid, long before I became an emergency paramedic, I remember the definition that the American Red Cross told me, which was it's the immediate and temporary care for someone who is either sick or injured until the help of someone more qualified can come and take over. And when I think about psychological first aid, if we take out the trauma side of it from someone being injured, it's quite similar. It's immediate and temporary care until someone else that's more qualified can take over. So with psychological first aid, we should be preparing the ground a little bit by understanding the situation. We need to learn about the crisis. And throughout the world, there's been a certain amount of misinformation that has been going around, and it's been difficult to learn about the crisis and learn about what causes things and how the disease is transmitted and what we should be doing. But at the same time, we should be informing ourselves about the available services and what support there is. What support there is in your community, what support there is in the health service, what support there is with families or non-governmental sort of organizations, variety of different types of support. We also need to learn about the safety and the security concerns that might be related to post-traumatic stress disorder. We need to observe for the safety of the individuals, because the person who has PTSD may need to have a certain amount of protection. We need to make sure that we're looking out for their basic needs. And we need to observe for people with serious distress reactions. And sometimes we'll find that someone with PTSD, the person who's watching this whole thing, they may develop PTSD as well. So we have to think about that a little bit. We need to also help people access their basic needs and services. We need to help them cope. And we may not be in a position of doing that, but someone trained in psychological first aid can get them on that track. We need to give them information, quality information, and we need to connect them with people, and it may be loved ones initially, and that's what pulled me out of PTSD, or it may be someone that could provide psychological or social support. Now, as occupational safety and health professionals, we're in a position to assist. We may not be the psychological first aider, we may be as well, but in our role as safety and health professionals, we need to be continually assessing the needs and concerns, which we do on a daily basis as part of our work. We need to actively listen to people without pressuring them to talk. And that's very important in psychological first aid as well. This whole idea of active listening, non-judgmental listening, making sure we understand what they're saying, making sure that we're doing more listening than talking. We need to comfort people to help them feel calm. We need to help them connect with information services and social support. And we also need to find ways to make sure that people are not going to be further harmed. Now, in order to do this, we don't need to be medical doctors. We don't need to be psychologists or psychiatrists. We don't need to be counselors or clinicians. We basically need to do the type of work we normally do, but orient it just a little differently, not necessarily to provide, but to facilitate the provision of psychological first aid and some follow-up. When I was working, as some of you may know, I worked for the United Nations for over 20 years at the International Labor Office, and I built a program dealing with psychosocial issues and the interrelationship of psychosocial issues at the UN, at the ILO. And one of the things that I learned in talking to psychologists and psychiatrists in building this program is one of the first things that people are told when they graduate from school as a psychiatrist, or they graduate with a degree in psychology. The first thing they're told is to get themselves a counselor, not themselves, but a trained counselor, because they're going to have problems and then they're going to need to share it. Being a psychological first aider also may carry with it the burden that they may be exposed to some of the things that they're trying to deal with as well. This is an information sheet. It's for you. It is not copywritten. It does not have anybody's logo on it. I designed it basically to talk about the fact that with post-traumatic stress disorder, if we can provide psychological first responder services, it's a primary line of prevention. Now, it's also important to think that the psychological first aider is a peer. So at our level, it might be someone at our same level of management. It might be another person, even from IOSH, who's working in a different facility. But it's a peer sort of thing where we don't need to worry about going to a hierarchy. We don't need to expose ourselves to some sort of problem. And you can see underneath there is, I don't know if you can read it or not, but according to the WHO, we may be called upon someone who's been impacted psychologically by the pandemic, and what we need to prepare, to look, to listen, and to link. So please feel free to download this, or actually it'll come from Michael shortly. And you'll look at the very bottom of the page and there's an information logo. And it says, for further information, contact. Now, I would like you, if you decide to download this and use it, put in the name and the contact information for the person who is going to be able to help someone if they have a psychological problem, or if they start sliding down this rather slippery slope toward post-traumatic stress disorder. The last slide that I'd like to share with you, and I realize this goes away a little bit from the confidentiality side, but it's my decision to share this with you. If you have any questions, if you want to get in touch, please feel free to email me at the email listed there. And that slide will also be published with the sheet that you have, or I'll just wait a second to write it down as you start thinking of questions and start putting them in the chat room, and Michael will sort through this. I would suggest if you have a question directly for me in the chat room, that you put Q as in Quebec, F as in Foxtrot, S as in Sierra, QFS in front of your question, which stands for questions for the speaker. And this will help Michael sort out the questions that need to be asked. So ladies and gentlemen, we're gonna go into questions. If the hosts don't mind, maybe we'll go over a few minutes if we need to talk a little bit more. But I want to thank you for your attention, and appreciate you listening to me, and hope that you're able to grasp some of these issues that are related to something that can be very, very devastating. One final, or actually two final points I'd like to make as we talk about this. One point which I find is extremely important. Today is World Suicide Prevention Day. Post-traumatic stress disorder does lead people to a state of mind where they may become suicidal. So I think it's also extremely relevant, Michael and the other organizers that we're doing this today, to address this particular issue. The second thing is that most of us on this call are members of the Institution of Occupational Safety and Health. We have this concept of one IOSH where we're working together. We're trying to build everything in one direction. Andrew brought it up in his opening remarks as well. Part of one IOSH also is a bit of solidarity amongst ourselves. And we do have something called the IOSH Benevolent Fund. And many of us have contributed. The IOSH Benevolent Fund can help members of IOSH that are in difficulty because of the current situation. So please consider also a donation, big or small, to the IOSH Benevolent Fund. So on this note, I will stop sharing my screen. I've talked enough, and turn it over to you, Michael, as far as question and answers are concerned.
I thank you, David, and thank you again for what was a very thought-provoking presentation. I'm sure all our participants have got a lot out of it. There are a few questions which I'll start going through now, some of which are kind of related. So for those people who've posted questions, don't be offended if I take these out of sequence, but I will get through as many as we possibly can. I'll start with two. The first one is from Alison Glass, and the second from Emma Gilmore. Alison has asked, is psychological first aid the same as mental health first aid? And Emma has asked, in your opinion, is mental health first aid a good basis for this?
Okay, the answer is yes, yes, and yes. Whether or not we want to call ourselves psychological first aiders or peer counselors or mental health first aiders, it's the same thing. Where we need to be a little bit careful, and I don't think it's the case in Ireland, I don't think it's the case in the UK, but it is certainly the case in the United States, that when we start using the word mental or psychological, there's sometimes a stigma attached to it. Now, I think in the United States, I haven't lived in the United States for over 30 years, but I think people are slowly getting over this stigma now. But it's taken many, many years to, it used to be that you put on a job application that I've seen a psychiatrist or I've had psychological counseling, and you can count yourself out of a job before you even sit down for the interview. But I do know that there are movements in Ireland to provide this sort of care, and whether you will call it mental health first aid, psychological first aid, it's there, it's important. And we had to be quite frank with you, it's very interesting. We have I've been running a series of 6 seminars for some of the volunteer leadership of IOSH to look at some of the issues related to COVID-19. And in a session very recently, and these seminars, they're like 10 people that are just simply openly discussing some of the issues, and we're trying to pull out some bullet points of it. And in this session, one of the things that came forward is there is an urgent need to actually even potentially have legislation that requires workplaces to have mental first aid or psychological first aid with a certain ratio, that there are so, just like we may do with a safety and health committee, we may do with first aid in the workplace, psychological first aid, and I'm really pleased that this was brought up by Alison. And I think, Alison, I think there was one other person who brought it up as well. I didn't catch the name, but I think, being a safety and health professional for a long time, since the 1980s, one of the things that I've recognized all along in many countries of the world, and I've worked in 80 countries, and one thing I found is OSH, or health and safety, you sometimes take the H away. It's occupational safety, and it's very rarely addressing occupational health. I think COVID-19 may be pushing us a little bit more to address some of the occupational health issues. And if we start talking about occupational health, the little brother in occupational health is mental health or psychological health. But if we actually look at the numbers of people that are suffering from poor mental health, the numbers are extremely high, they're just hidden. So it's extremely important, and I appreciate the fact that this came up in the chat. Michael?
Very good, yeah. Question from Nigel Ashcroft. Thank you for your generosity in sharing your story, David. You spoke of a single event. Is this definitive for PTSD, or is it increased by cumulative experience? Also, is the presentation of PTSD similar to that of grief?
Okay. It's interesting that Nigel, how you doing, Nigel? Nigel's an old friend. I think your questions are very germane. Is there a cumulative effect of different things with PTSD? I really can't answer that. I think it's more an individual sort of thing. I'd be happy to do a little bit of research and come back to you on this if I can, and ask some questions of people that may know. I had a lot of other experiences that may have had a cumulative effect, but this particular event that I lived through it was the trigger factor. It was the factor that actually made it happen. So it's difficult to say. Now, as far as grief is concerned, I'm hoping that we can recognize PTSD long before we start grieving. Okay, it's something we need to think about early on. And in fact, when I spoke to Michael about this, and Michael talked to the branch chairs and Catherine about this, one of the things that I stressed is we need to start hitting this very, very early. We need to hit this not in 6 months from now, not in 2021, because people are suffering from PTSD now. And if we can get in early enough, before we start seeing some of the major problems, if we can start setting things up a little bit, we're going to be in a far more positive position to be able to deal with it early and to nail it early. So it's going to be like happened with me and not my two colleagues that went through it. Nigel, I hope I've answered your question. If I haven't, please come back to me.
Okay. Go back to one of the earlier questions from Jason John Douglas. With regard to signposting and support, what is the right amount? The fear of overindulging in personal situations in the workplace. Senior management in old-style management workplaces are very nervous of COVID-19 already on the impact on their business. Does the panel have any views on this topic?
Okay. PTSD is something that is there. PTSD is something that it's maybe not easily identified, but it is something that is present. I shared with you numbers from a study that was done by Professor Sherry Amor from Northern Ireland. And when we see numbers like this cropping up, we know that it's present in society. If we can deal with it early, there is going to be definitely, in my mind, a return on investment for employers. If they invest a little bit in psychological first aid, if they invest a little bit in exploring what is post-traumatic stress disorder, a number of these issues, what we're going to see is that we're going to be able to get people back to work sooner. We're going to be able to help people more effectively. We're going to reduce absenteeism. We're going to reduce presenteeism. We're going to have a variety of different positive things. And I think we need to look at the positive side of dealing with the stress and the PTSD. And stress is an antecedent of PTSD. They can indeed be linked. They can indeed be related. But I think that's the best way we can deal with it. I hope I've answered the question. If not, please come back to me.
Okay, and a question from Alison Glass. There is a meta-analysis research by Amy Maslowski concludes that mental health first aid training is positive for the trainees, but the results are inconclusive for recipients. HSE research also concludes that there is limited evidence to support the effectiveness of mental health first aid in workplace settings. How would you respond to that?
Okay, I would disagree. There's been quite a bit of work done in a number of different countries that have indicated that what used to be the initial in-depth briefing of someone that's gone through trauma was the most effective tool for dealing with PTSD. And research has shown that it is mental health first aid that is far more effective than in-depth sort of interventions. So what we find now is this whole concept of having a peer-to-peer relationship where people can talk to someone at the same level without fear of retribution to actually get things moving in a solid, positive way for the individual, or at least let me share with you something. When I worked at the ILO, a couple of planes crashed into the World Trade Center, and I was sitting in my office in Geneva, Switzerland, and very shortly after those two planes crashed into the World Trade Center, I was called by the Director General of the ILO, a gentleman by the name of Juan Samavia, who was on his way to New York, who was on his way to the site of the World Trade Center. And he said, what can we give them? What can we offer them? And my suggestion was we had a training package that they could use, and I was happy to bring it forward. New York did not want the training package. They felt they could do it on their own. But the second piece of advice, and in fact, a medical doctor from the New York Fire Department, Dr. Carrie Kelly, daughter of a battalion chief, If it sounds Irish, many of the firefighters in the United States are Irish or of Irish origin. And Carrie and I had long talks about this, and Carrie and I came up together with the idea that somehow we need to work with the structure of the New York administration and suggest that everyone that has been associated with the World Trade Center, be they firefighters, be they paramedics, be they police officers, be they public work officers, whatever it may be, even transit officers and other people providing support, they get at least a chance to look into the eyes of someone that might be able to help them. Maybe they're not going to say a word. Maybe they're not going to shake hands. Maybe they're not going to ever contact them again, but have an initial contact. And with that, there is an avenue if something starts to fall apart, that there is an avenue that they can, there's a door they can enter and start to get some support. Basically, we're talking about psychological first aid. We're not necessarily talking about trained counselors, but just individuals that can help them work through it. Interestingly enough, the trade union of the New York City Fire Department said, absolutely not. We're tough. We don't need this kind of mumbo jumbo psycho-babble. We don't want it, and it's not going to happen. And it didn't happen. And a study was done 5 years post 9/11. Some of you may have read about it, where we saw a dramatic increase of attempted suicides, of alcohol consumption to the point of addiction, of drug consumption, of acts of violence, of physical and psychological violence, verbal abuse, and domestic violence amongst the people that were involved with the 9/11 situation. So to return to the question, I'm sorry for the length of the answer because I'm perhaps pontificating a little bit, and I don't mean to be on a soapbox. But what I find is very important is to have someone with a little bit of training that can receive someone that can say, here's a door. If you need to, come in, let's talk. If we need to go beyond talking, we'll go beyond talking. Maybe I can accompany you if we need to accompany you. That's not a bad place to start. And you know, that door might not only be psychological first aiders, it might be the church, it might be another sort of organization that can deal with it, but we'll need to find a way through it. Michael.
Very good. Sort of, question from Richard Norman. Let me just get that. As this is a totally new situation that we all find ourselves in, what relevance does any previous experience play? With the global effect of COVID, what could we all learn from AP that have experienced and lived with through SARS? What does this region of the world have to share with the rest of us?
We have found that reading the studies that were done by the Chinese regarding the different forms of COVID virus that have surfaced, and there's also been MERS coming out of the Middle East. But being able to study the people that have been working on these and understanding that we're from different cultures and there are different social dynamics that are involved in this kind of thing. But we need to understand these, Andrew used the word earlier, comorbidities. Comorbidities are associated diseases and associated problems with this. But as was just said, it's a new game book. We're learning to understand the disease, but we do know that one of the major problems that is surfacing and will continue to surface, especially post-disease, are some of these issues. The lack of social support because we're isolated, the inability to be able to communicate with people. And there's a variety of other problems that we're facing as we emerge from COVID-19. For example, people working at home. And people are suddenly working on sofas, on laptops, and they're ending up with back injuries, back problems. They're ending up with wrist problems. There's all kinds of things that are associated with it. But we can be fairly certain that the psychological problems associated with COVID-19 and post-traumatic stress disorder are there. They're strongly there, and we need to deal with it.
Very good. One from Francis Hackett. COVID-19 is generating significant stress, not just for people who get the virus, who have a close relative who have the virus. Would you agree that the presence of the virus is also a source of stress for vulnerable employees due to its very existence? And such fears need to be recognized in the workplace. These fears have a potential negative impact on the work environment.
A close friend of mine from Dublin works, and a member of IOSH, works at the University in Dublin. And he manages facilities, he manages some of the fire safety in Dublin, and he shared with me what's going on in his university. And I won't mention his name, but I won't mention his university. Some of you may know, but I'll keep that to myself for the time being. And he talked about fear. He talked about fear in the faculty of the university. And many of the faculty are over 50, over 60, some of them over 70 years old. Being exposed to younger students who may be less worried, they may feel less vulnerable, they may feel they're not going to get the disease. So if we can take this example and address this question a little bit, what can we do to deal with these kind of fears that are associated with COVID-19? Now, will this fear generate post-traumatic stress disorder? It's difficult to say. It's an individual sort of thing. It's probably not quite that level, but it certainly is a stressor. It's certainly things that creates a certain high degree of anxiety in this situation. And we talked about this also in one of the seminars. And I think traveling to London, I woke up the other night thinking about this and saying, how do we deal with this gap between generations? And it's not all the students are that way, not all the professors are this way, but it is there. And I was thinking about being on the London tube and all of a sudden hearing, mind the gap when the doors open. Well, I don't want to mind the gap. I don't want to bridge the gap. I want to fill in the gap. And how do we fill in the gap? And one of the seminars that I've just run suggested, and it was very, very interesting, that we think about finding ways of getting people benevolently, actors, actresses, people that can pass a message, to find a punchy, attractive message that's going to change people's thinking and change people's behavior toward this COVID-19, to address some of these fears. You know, how do we get the student, the young student, to be a little bit more attentive to this kind of situation and to take care and take precautions when they're in that kind of situation? And what are the mechanisms to do it? I think in Ireland, I think around the world, we can be creative. We can work together and surface ideas, punchy, crisp ideas, maybe brought over by actresses or actors or different people that might be able to help us work through it, but to share messaging in a positive, it's like behavioral safety and health. We find messaging with something that's a little bit punchy, a little bit crisp, and at the same time will change the behavior in a positive way to make it happen. And I think that's the best way we can deal with it. Again, I'm sorry for the length of the answer.
That's okay, no problem. Excellent question from Adele Corrigan. Are there any, sorry, I've just lost it off the page. Hold on a second. Are there any identified groups of persons that are potentially more or less likely to develop PTSD given their pre-event mental health or experiences?
Potentially, yes. And I shared with you some of the precursors in the slide presentation. Have a look at the slides. I'm happy to go back and look at them if you want to. But one of the things we looked at, some of the things that actually set people up toward post-traumatic stress disorder. So think about some of these things that are some of the antecedents of post-traumatic stress disorder. And, you know, when you I talked about risk factors that increase the risk. And I talked about seeing others that are hurt or affected, seeing a dead body, having experienced childhood trauma, feeling helplessness or extreme fear, lack of social support. These are things that, and experiencing high levels of stress after an event, these are things that can indeed create it. But even people, as I mentioned earlier, including myself, that are highly experienced, highly competent to deal with a medical emergency, but highly experienced and had a lot of visual sort of, I won't say stimulus, but visual sort of things where we had seen dismembered people in car accidents or people that were engaged in some difficult situations with law enforcement. I was head of a team where there was a shootout, and witnessing this kind of thing. Yeah, I'm tough. I really deal with these things well, but do I? and all of a sudden that little twig may snap. It may be the straw that broke the camel's back. So there are certain antecedents, but they vary dramatically individual by individual.
Very good. Well, that's all the questions answered. There's we've gone over time a little bit, which I hope most people don't mind. There's some very nice comments in the chat that we don't really have time to go through, but I will pass all your compliments and your sort of statements on to David sort of after the event. At this stage, I would just like to, if we have no other questions, I would like to thank everyone involved. I'd like to thank sort of Andrew for his opening address. I'd like to thank David for an exceptional presentation. It's really sort of thought-provoking. I'd like to thank the chairs of the 4 branches in the regions for all their assistance and support in getting this up and running, getting this event hosted and held. I'd like to thank sort of all of the attendees who have turned up, and to my colleague Catherine for her help with the production. And at that point, unless anybody else has any other input, I'd like to wish you all good evening.